Good morning, good afternoon, good evening. My name is Guy Marks. I'm talking to you from Sydney, Australia. I'm a physician and I'm the president of the union. This symposium on modelling to advance prevention has been organised by the TB Modelling and Analysis Consortium, TB-MAC. TB-MAC is a Bill and Melinda Gates Foundation funded consortium focusing on TB epidemiological and economic modelling. It's part of the WHO Global Task Force on Impact Measurement. It focuses on three key areas. The first area is strengthening networks, ensuring strong and effective links between decision makers, modelists, and economists. The second area is on creating solutions, ensuring new high-quality resources are available to decision makers. And the third area is on empowering decision makers, ensuring TB decision makers are better equipped to integrate these resources into their decision making. All of this is designed to lead to improved TB control, policy decision making and practice at both a global and a country level, and also to increase the effectiveness and efficiency of TB control and policy and practice, again, both at the country and global level. So at this point, I'll hand over to my co-chair, Blessy Kumar, who will introduce the speakers. Thank you, Blessy.
Thank you very much, Guy. Good morning, good evening, good night, everyone, depending on where you are. And we are delighted to welcome you all to this very special session on modeling to advance prevention. We have a great list of panelists for you, experts in their own areas, who will bring their perspective and experiences to this topic. We have Pereira Zindoga from Mozambique, who is with the National Tuberculosis Control Program, Ministry of Health, Mozambique. We have Chatika Veerasurya, who is part of the TB modeling group. We have Courtney Yon from Harvard, USA. We have Yongji Jo from the Johns Hopkins University. And we have Arne Wondel from South Africa, who will bring a very, very interesting perspective, a lived perspective representing the communities affected by TB. So great session. We will have question and answers at the end of the speakers, and we encourage you to post your comments and questions in the chat box. We will be following that up and take them up at the end of the presentation. We can now start with the presentation, please. Thank you.
Hello, everyone. I will present OTMA's investment in Mozambique tuberculosis response, result of OTMA modeling studies. My name is Pereira Zindoga. I work at NTP in Mozambique. I don't have any conflict of interest to report. As a background, Mozambique TB incidence is among the highest in the world, 551 cases per 100,000 in 2017, while the treatment success rate for new and relapse cases is high, 90% in 2017. MDR notification and estimated burden to drug resistance due to overall low diagnosis rate and limited DR testing. 6.2% of national status plan need was found in 2016. Approximately 95% of TB response was external funded. The country will benefit from more effective and efficient TB response. If we analyze the total budget for NTP in 2017, you can see the 53% was from Global Fund and 31% was World Bank, only 5% was domestic funds. If we see the estimated expenditure on TB response, you can see 56% was for screening, 27% for treatment, 11% for prevention, and 6% for management. What was our objective was to project the current and future trend of TB epidemic, provide the recommendation for resource allocation, and estimate the impact of reaching the NTP target. For that, we do the assessment of the disease in Mozambique. We analyze the programmatic response of TB in Mozambique, and we define the objective and constraint. We gather all these together and run the different scenarios, and we optimize the algorithm and interpret the results. Over all these results, we projected health and economic outcome to 2035. Our results, we see the number of new cases projected to remain fairly constant as the population in Mozambique increased rapidly. The incidence of TB pulmonary projected to decline from approximately 500 to 300 per 100,000 in 2035. We can see also if we project the incidence in adults HIV positive compared to HIV negative, you can see the in HIV negative, the TB incidence will increase, but in HIV positive, the incidence will decline, likely to the increase of cover of the heart. If we see the TB cascade in Mozambique, we can see about 50% of new active TB case was diagnosed. As a result, despite high treatment success rate, about 41% of all new TB cases complete the treatment. Now, if Mozambique meet national and international target and sustain this target, we can reduce the TB incidence and the TB-related death up to 8% relative to current condition in 2035. If we optimize the current funding allocation for TB, we could increase annual funding for outpatient screening from 10 million to 30 million.2. We could increase the funding treatment to accommodate the increased number of notification, and prioritization should be given to case finding program for key population. If we see, if we can optimize just the case finding program, we could screen all patients living with HIV, could reduce the house screening community outreach. You can increase cover of program target key high group, and you can double the cover of household contact tracing. If Mozambique could optimize the budget on, and the impact of that on key indicator in the overall population, if we assume that the budget will be constant until 2035, relative to current condition allocation, optimized allocation of current spending could reduce the number of active TB infection by 19%, reduce the number of TB-related death by 18%, and reduce the rate of TB incidence by 11%. In conclusion, while the rate of TB incidence is decreasing, the number of new TB cases is projected to remain fairly constant. Diagnosis remains the most significant breaking point in TB care cascade. About 50% of new active TB cases were diagnosed with TB. About 41% of new active TB cases successfully completed treatment according to WHO report of 2018. Meeting and sustaining which is targeted for 2025, is projected to yield significant reduction in total number of active TB cases and a TB-related death of up to 50% relative to current condition in 2035. Relative to current allocation and optimized allocation of current spending could reduce the number of active TB infection, reduce the death, and reduce the rate of TB incidence. Thank you. I would like to acknowledge all the team of NTP in Mozambique, principal who work on this project, the team of University College in London who work on that, World Bank and Barnett Institute. I would like to thank all of them for this support for this slide. Thank you.
Good afternoon. Thanks for listening to this talk at the symposium. Before I begin, I'd like to disclose that I have no conflicts of interests and that this work is funded by the UK Medical Research Council. I'd like to present some work today that we're doing at the TB modeling group at the London School of Hygiene and Tropical Medicine. So my name is Chatika Veerasuriya. I'm a current PhD student working with Professor Richard White. And this work centers around attempting to estimate the impact of novel TB vaccines on multi-drug resistant tuberculosis in China and India through the use of mathematical modeling. So as all of us here are aware, multi-drug resistant TB is an emergent threat which threatens to impede global TB control efforts. And as we know, the last couple of years have been particularly exciting from the perspective of TB vaccines, with the development or progress of at least a couple of candidates through the clinical pipeline, notably M72 AS01E and BCG revaccination. However, the impact of these new vaccines on RR-MDR-TB is unknown, and that is the question that we're trying to provide some insight into through this work, particularly from the perspective of the epidemiologic impacts and their health economic impacts of these new vaccines on RR-MDR-TB by the WHO NTB target year of 2050 in China and India. So to address this question, we took three basic steps. First of all, we constructed a deterministic, compartmental, drug resistance, age, and treatment stratified dynamic transmission model of tuberculosis to past and current epidemiology in China and India. We then predict baseline future TB scenarios using this model, that is, futures without TB vaccines. And then into these future scenarios, we implement a vaccine in 2027 with a range of characteristics. Specifically, a prophylactic vaccine which prevents against disease with efficacy between 30 to 90%, with 5 to 10 years of protection, which is effective across a range of host infection status. So this vaccine could be effective in those with infection, known as a PSI or post-infection vaccine, or those who are either without or with, so pre and post-infection, known as a PR and PSI or PNPI vaccine. And the vaccine was assumed to be deployed to 9-year-olds routinely, achieving 80% coverage, and to 10-year-olds and above, achieving 70% coverage every 10 years from 2027. So in terms of the future scenarios, that is the future baseline scenarios without new TB vaccines, we implemented essentially a spectrum of possible scale-up. For both countries, we implemented what was known as a status quo scenario, where the TB program does not change after 2018. In contrast, for each country, we also implemented what is known as a policy scenario, where we have country-specific scale-up of programmatic management of TB up from 2018 up till about 2025 and beyond, depending on the country and depending on current and planned national policy. So here we have once again a summary of the analytical approach, the three main components. First of all, the model. Second of all, the intervention, that is the vaccine. And third of all, the endpoints. The endpoints being in 2035 and 2050, the epidemiologic endpoints being the percent reduction in the incidence and mortality rate due to MDR-TB, and the number of deaths and cases due to MDR-TB which are averted, the health economic endpoints of cost per DALI averted and annual budget impact, and finally, health system endpoints such as the number of RR-MDR-TB treatments averted. So moving on quickly to some of the results. Here we see the results of implementing a 10-year 50% efficacy vaccine in 2027 on the RR-MDR TB incidence rate by 2050. And we can see there's a substantial reduction in MDR TB incidence, up to about 65 to 70% in both China and India. And that the reduction due to a PNPI vaccine is, of course, slightly higher than that due to PSI vaccine. Similarly, here we see the equivalent result, not for just MDR-TB, but for all TB. And once again, we see, as expected, a higher impact of PNPI vaccination, up to about 50 to 60% in India and slightly lower in China, with a, again, correspondingly lower PSI vaccine effect in both countries by 2050. Here we have a summary of the cost effectiveness analysis that we performed. And what we found here is that in India, all vaccines modeled at all PSI and PNPI vaccines that we modeled at 50% efficacy and 10-year duration of protection were found to be highly likely to be cost effective at all the country-specific willingness to pay thresholds that we compared against. In contrast, in China, we also find that vaccination is, on the whole, quite likely to be cost-effective, with a probability of greater than 94% for PNPI vaccination at even the lowest willingness to pay threshold, in comparison to a PSI vaccine, which had a slightly lower probability of cost-effectiveness, approximately 75% at the middle willingness to pay threshold, as demonstrated on this graph. We also found that implementing a vaccine was likely to avert a substantial volume of treatment, up to about 1 million cases over the time frame of the model in both China and India of RR-TB treatment. And here, finally, we have the results of the baseline uncertainty analysis, so the impact of differential programmatic management of TB in the future. And this is the underlying epidemiologic effect of scaling up non-vaccine TB management. And what we can see here in this graph, the lines represent the proportion of incident TB, which is either new transmission in purple or due to relapse and reactivation in yellow. And I should say this is incident RR-MDR TB. And you can see that by scaling up programmatic TB management, we shift the RR-MDR TB epidemic from one which is predominantly driven by new transmission towards one which is roughly equally driven by new transmission and relapse and reactivation. And this has essentially two main consequences for our analysis. First of all, while the vaccines effect a similar relative change in both the status quo and policy scenario, the absolute burden of a disease that is averted by vaccination is lower in the policy scenario due to an absolute reduction in the amount of disease. And as a consequence, we also find a slightly increased incremental cost effectiveness ratio, suggesting a slight decrease in cost effectiveness in the face of programmatic management scale-up. As with all modeling studies, this study has a number of limitations, in particular due to the limitation and paucity of data that we have to calibrate the MDR-TB epidemic, and the fact that the range of interventions which we modeled is actually quite limited. We assumed an invariant MDR-TB regimen efficacy, and we did not model any new drugs or new diagnostic modes, and the costs of our cost-effective analysis are kept fixed over the duration of the analysis. So our preliminary conclusions from this analysis so far are essentially presented here. We estimate that vaccination is likely to substantially reduce RR-MDR-TB burden in both India and China, and that the epidemiologic impact of vaccine is maintained, certainly proportionally, across some scale-up of programmatic management of TB. Vaccination may avert a substantial volume of RR-MDR-TB treatment over this duration of time, and finally, there's a high probability of cost effectiveness of vaccination at country-specific willingness to pay thresholds. Thank you. So I'd just like to acknowledge the various contributors to this work, the TB modeling group, of course, but also funders, collaborators, and colleagues at WHO and the country TB programs, and colleagues at ERAS, now IAVI, and the China Centers for Disease Control and the International AIDS Vaccine Initiative. Thank you.
Thank you. I have no conflicts to report, but I do have grant support to acknowledge, including TB-MAC, which is the sponsor of this symposium. The context for this study is the 2018 change in WHO's contact management and preventive treatment guidelines. Before 2018, WHO recommendations for high-income, low TB burden countries were to test contacts for TB infection and treat those who had latent TB infection. But in other countries, preventive treatment was only recommended for child contacts under 5 years old and people living with HIV. In 2018, WHO got rid of the double standard, making all contacts eligible for preventive treatment. But many countries with high TB burdens do not currently have a lot of capacity for TB infection testing, and concerns have been raised about its utility. Specifically, if the prevalence is very high, the prevalence of TB infection is very high, the negative predictive value of the test may be very poor. And second, if a vast majority of contacts test positive, is it even worth the effort to test everyone? There's also logistical barriers here, including cold chain storage and tuberculin shortage, and the need for laboratory infrastructure if IGRAs are being considered. So all of these questions make it a reasonable question to ask in high burden countries of what's the best policy in terms of integrating testing into the contact management guidelines. So in this study, we set out to address this issue. We wanted to know, in a high burden setting, when is TB infection testing useful in household contact management? And as a way to answer this, we wanted to know how many incident TB cases and how many severe adverse events would be expected if we just treated all contacts without testing. And how would this differ if we tested first and only treated those who were TST positive? We used a decision tree model structure to model these two different contact management strategies. So the first strategy, like I said, is giving preventive treatment to all household contacts after ruling out TB disease. And the second strategy is testing everyone with a TST and giving preventive treatment only to those who test positive. The model structured here first branches to say that contacts are either going to be TST positive or negative. They either get preventive treatment or not based on the algorithm that we're using. And if on treatment, they either have a severe adverse event or not. And anyone who, all of these contacts have a risk of developing incident TB disease. We modeled different age groups separately, and we created different models assuming different prevalences of TST positivity to see how these would impact the outcomes. We used data sources from high quality cohort studies and randomized controlled trials. We got the age stratified risks of incident TB from a study based on an Australian cohort and represented the cumulative risk from 3 months to 3 years after infection. The risk ratio for progression based on TST status was taken from a large prospective cohort study in the UK. The protective effect of preventive treatment was taken from a network meta-analysis of trial data. And the age stratified risks of treatment associated grade 3 and 4 adverse events was obtained by contacting the authors of the most recent 3HP, that's 3 months of weekly rifampicin and isoniazid, and 4R, which is 4 months of daily rifampicin, the efficacy trials done on those two regimens, comparing them to isoniazid. To show how all these data combine, I'll show you two different scenarios that we modeled. This slide shows the risks of TB disease and severe adverse events per 1,000 contacts associated with the two different treatment strategies if we consider children up to 17 years old in a situation where 25% of them have a positive TST result. The treat everyone strategy is on the left, and the strategy of treating only those with a positive TST is on the right. If we compare the two strategies, you see that if we treat everyone, we get approximately 10 fewer cases of TB per 1,000 contacts and around 2 to 4 additional adverse events compared to if we only treat the children with a positive TST. And the results for these three different preventive treatment regimens are slightly different, but more or less on the kind of same order of magnitude. This next slide shows the exact same analysis, but considering adults over 65 years old, 25% of whom have a positive TST result. So because adults are less likely to develop TB disease once infected, and older adults are more likely to have severe adverse events, then the numbers change. So if you compare the two strategies, you can see that treating everyone prevents approximately 2 fewer TB cases, or prevents approximately 2 more TB cases per 1,000 contacts. But the increase in adverse events is a lot larger, and it depends on the preventive treatment being used much more than it did for children. This graph summarizes the comparison between the two treatment strategies and shows how this comparison differs by age, regimen, and TST positivity prevalence. So on the vertical axis is the difference. So what we're looking at here is the difference in risk between the strategy of treating everyone and the strategy of treating only people with a positive TST. The left panel shows risks of TB disease, and the right panel shows risk of adverse events. So you can see that they're going in opposite directions. The left panels are showing fewer cases of TB disease developing, whereas the right panels are showing more cases of severe adverse events based on this strategy of treating everybody rather than only treating people with a positive TST. The upper panels show the numbers for treatment with 3-HP, 3 months of weekly isoniazid and rifapentine, the lower with 4R, or 4 months of daily rifampicin. The different colors represent different prevalences of TST positivity, and age group is on the horizontal axis. So what we can see is that for a cohort of 1,000 child contacts under 18 years old, 10% of whom have a positive TST, treating them all with 3-HP would lead to 15 fewer TB cases and 5 additional severe adverse events compared to treating only those with a positive TST. In contrast, for a cohort of 1,000 adult contacts over 65 years old, 50% of whom have a positive TST, treating them all with 3-HP would lead to 1 fewer TB case, but 42 additional severe adverse events compared to treating only those with a positive TST. But if 4 months of rifampicin were used instead, there would be only 12 additional severe adverse events in this same adult cohort. To illustrate how these different treatment strategies would play out at a population level, we considered hypothetical cohorts of contacts whose distributions of age and age-specific TST positivity were based on published cohorts, one from India and one from the Netherlands. The contact cohort in India was generally younger and had a higher TST prevalence at all age groups than the cohort in the Netherlands. As before, we compared the strategy of preventive treatment for all contacts once TB disease has been ruled out versus a strategy of treating only those with a positive TST. In India, the treat all approach was expected to result in 3 to 4 fewer TB cases per 1,000 contacts compared to treating only those with a positive TST. It also led to between 3 and 9 additional severe adverse events, depending on which regimen was used. In contrast, in the Netherlands, the treat-all approach was expected to result in 2 to 3 fewer TB cases, but between 10 and 38 additional severe adverse events. This analysis shows how the same contact management algorithm can result in very different risk-benefit profiles depending on the epidemiology of the setting where it's used. In India, the trade-offs between the treat-all approach versus the approach of treating those with a positive TST are relatively balanced in terms of preventing more TB cases or incurring more severe adverse events. one could reasonably argue for one approach or the other depending on logistical considerations. But in the Netherlands, the increased severe adverse event risk caused by a treat-all strategy compared to the more modest reduction in incident TB cases would make it very difficult to argue for this strategy. In conclusion, for adults under 18 years old, our model suggests no clear benefit to using TST to determine who should receive preventive treatment when the prevalence of infection is high. And for adults, it's different, and minimizing adverse events can be achieved by focusing treatment only on those with a positive test for infection, using a rifampicin-only regimen, and building robust systems for adverse event monitoring and management. Thank you to my collaborators, to the people who provided unpublished data for this study, and to the TB-MAC for funding. Thank you.
Hi everyone. Today I'm going to present about cost effectiveness of scaling up short course preventive therapy for tuberculosis among children across 12 countries. My name is Young-ji-jo, and I'm presenting on behalf of my team at Johns Hopkins University and Orem Institute. Before beginning, I want to disclose potential conflict of interest that this work was funded by Unitaid through Impact for TB project. As a background of the study, around 1 million children worldwide develop active TB, and 240,000 children die every year, which is nearly 1 in 4. 90% of children who die from TB worldwide when untreated. Many previous studies show household contact investigation for TB detection and latent TB treatment is effective. However, logistical and structural barriers have hampered the implementation of routine and systematic contact investigation, and only 27% of young child contacts received preventive treatment in 2018. This map shows the global TB burdens for children under 5 and 15 years old, showing that greater mortality rates in Sub-Saharan Africa and Southeast Asia countries. So the objective of the study is to estimate cost and cost effectiveness of household contact investigation for children under 5 and 15 years old across 12 high TB burden countries. In terms of method, we took health system perspectives for 1 year of intervention in 2018, and we measured the impact as a number of deaths averted between contact investigation scenarios relative to status quo. We presented our finding as cost per death and liability. For intervention group, we considered a household contact, child contact screening identifies symptomatic children for TB test, which assuming about 37% of total eligible child contacts. We provide TB treatment if TB tested positive, and provide 3-HP preventive therapy to all child contacts regardless of symptom and without LTBI testing. On the other hand, for status quo, we assume the coverage of existing TB treatment based on current TB, child TB notification, which is only 0 to 14%, and 9 months of Eisenhower preventive therapy, IPT coverage, varying from 4 to 36% reported by countries. We constructed a decision tree model, as you see in the figure, which represents child contact population characteristics for TB disease and TB infection. We assumed 8% of TB disease prevalence and 48% of TB infection prevalence out of total child contacts for children under 15 years old based on the published literature. We assumed that TB prevalence would be very low, about 1%, among asymptomatic children, presented as a dashed white box named TB below, and representative relative probabilities of TB treatment and 3-HP preventive therapy of household contact investigation were assigned to the dark blue and light blue boxes with a green dashed line in the middle. For those who are infected as latent TB, we assumed 5% and 10% early and late reactivation rates. We assumed TB case fatality rates with and without treatment. For household contact investigation, we assumed TB diagnosis and treatment would generally be initiated early in the course of disease, and therefore assumed no mortality for child contacts with TB disease who received TB treatment, which denoted as a white box labeled death on the top right side. We assume the probability of existing TB treatment in the status quo, light blue boxes on the right side of the branches, named TBTX, based on child TB case notification reported by countries. In order to estimate the size of eligible number of pediatric household contacts, we used the established approach from a published literature. We estimated this number as an average number of children under 5 and 15 years old per household in each country, based on the most recent demographic and health survey. We then multiplied this by the number of adult pulmonary TB cases notified in each country by each country to WHO in 2018. This table shows the list of 12 countries and estimated annual number of children for contact investigation, which consists of about 1 million children under 5 and 3.5 million for children under 15 in 12 high-value countries. The size of target population varies by countries, but India has the largest target population, over 50%. This table shows the risk of key epidemic and cost parameters. We used country-specific estimates for TB notification rates, case fatality rates, and IPT coverage, and cost per screening, testing, and treatment. However, we used a standard estimate for treatment efficacy, LTBI reactivation rate, and prevalence of symptom and percentage of toxicity, because we don't have a country-specific estimates on each parameter. This figure illustrates relative amount of health impact for each scenario. As we assume the same population characteristics across the scenarios, the incremental TB cases were mainly determined by number of reactivation, which is lowest for TB and 3HP treatment intervention relative to TB treatment only scenario and status quo. TB treatment only has slightly greater reactivation than status quo due to a lower false positive of TB testing than those in status quo. The incremental cases and deaths averted are greatest for the TB and 3HP treatment intervention without surprising. The total intervention cost for TB and 3HP treatment intervention is estimated about 600 million, while status quo is about 300 million as 2018 US dollars. Household visit screening and TB treatment consist major cost of the intervention. This figure shows the incremental cost effectiveness ratio estimates across scenarios by age groups. Cost per death averted for child contact investigation with TB and 3HP treatment is about $10,000 per death averted and $350 per daily averted for children under 15 relative to status quo. Including 3HP in addition to TB treatment only scenario can improve cost effectiveness substantially from about 700 to less than 60% per daily averted. Cost effectiveness of household contact investigation improves about twofold if the target population is children under 5. The one-way sensitivity analysis reveals the key drivers of cost effectiveness is TB prevalence among child contacts and sensitivity of TB testing diagnosis and untreated TB case fatality. In our probabilistic sensitivity analysis, 30% of simulation fell below a priori stringent cost effectiveness threshold of 10,000 per death averted for children under 15 years old, whereas 80% of simulation fell below a threshold of 20,000 per death averted. The willingness to pay threshold, however, were substantially differed by countries. To summarize, contact investigation with active TB treatment and 3HP is highly cost-effective compared to the status quo, which is favorably comparable to other home-based intervention in low and middle-income countries. Country-specific cost effectiveness would fall between $100 and $1,400 per daily averted for children under 15 years, with higher estimates in wealthier countries. Our study also has some limitations that we found there are lack of country-specific data, such as pediatric TB and LTBI prevalence, and natural history of pediatric TB and reactivation, and case fatality ratio of untreated pediatric TB, case notification among child contact who subsequently developed TB, and cost of performing household screening. We did not include HIV and disease vaccination and MDR TB status in our analysis. While this may change the point estimate, but would not change the conclusion on the relative cost effectiveness of household contact investigation relative to status quo. In conclusion, household contact investigation for TB with extensive provision of 3HP to children and adolescents is likely to be cost-effective. Cost effectiveness is optimized in regions with high TB prevalence, low existing TB case notification level, and coverage of preventive therapy. Future evaluation of implementation, including the collection of setting-specific data, will further inform decision-making. And finally, I'd like to acknowledge our co-authors and collaborators at Johns Hopkins Bloomberg School of Public Health and Center for Tuberculosis Research at Johns Hopkins School of Medicine and Oren Institute. We also thank for the funding support from Unitaid for this. And thanks for listening.
We thought it was just a dry cough, just sinusitis. We didn't realize that it was MDR TB. I didn't have any other symptoms. There was a time I was waiting for the sensitivity results and Anna was at work.
I was at work when the pulmonologist phoned me, and the first thing he told me is, I'm sorry, things are looking bad.
When he got home, he wanted to comfort me, and I realized that I've got an infectious disease that's really dangerous.
She had locked me out. I wasn't able to talk to her. There's a glass door, but she was in tears.
I was very upset, so I was crying a lot. And he wanted to come and give me a hug, but I knew it's just going to be too dangerous, so I locked the door.
This was the worst kind of helplessness. "6 years living with latent MDR TB. 6 years too long. Time to end it." Day 1 of 200.
I was not screened after 6 weeks of intense exposure, and when I became ill after 2 months, I wasn't treated. When I eventually attempted TB preventive therapy, I quit after 6 weeks, literally crippled by a drug with 4 black box warnings on it.
I was tired when I started this treatment, and I'm more tired now. I've had opportunistic infections, herpes, candida, phototoxic skin reactions, progressive joint and tendon pains. I've been able to walk properly in the past 2 weeks after bilateral Achilles paratendonitis. And my memory has been just about missing, can't concentrate. I can't find things, most significant being my wedding ring. It's been missing for 2 weeks, presumed lost indefinitely. And today I found out that a friend and colleague who had survived MDR TB passed away. Most likely reason for death was renal failure, which was originally caused by the amikacin. So treatment-related death after long suffering, including deafness as well. And today I become a statistic myself. 6 weeks and 1 day later, I'm going to become a much maligned TB defaulter. Can't continue this for another 5 months without even knowing whether the treatment will work. And that's the bottom line. We need better diagnostics, and we sure as hell need better treatment for latent and active drug-resistant TB. So this is my last tablet. May it fall where it has to. Still committed to ending TB, but just not like this.
Good day, colleagues. I'm a clinician trained in epidemiology, but I can't pretend to be a modeler. I can't even pretend to understand the models. just like I can't pretend to understand why we are not taking TB prevention seriously. Let me use the most basic model of all, just some basic math. We know that nearly 2 billion people are infected with TB. We also know that on average, 1 out of 10 people that are infected will become sick with active tuberculosis. So let's make that about 200 million new episodes of TB. We also know that on average, TB transmits to about 10 to 15 people before being diagnosed and started on adequate treatment. That's even assuming that we are diagnosing and starting enough people on treatment. We know historically we're missing a third of them. So where does that get us? 200 million transmitting to another tenfold number of people. That gets us right back to where? 2 billion people living with TB, like me. And that doesn't even address people truly like me who are living with latent multi-drug resistant infection. We haven't even touched on people like me yet. So my question is, why is this not a bigger discussion? Why are we focusing on trying to treat ourselves out of an epidemic, even knowing that if we magically stopped all active TB today, all the latent infection will come back, reactivate, and transmit, and we will sit with the same problem over and over and over. My next question is, if the modeling is so complex, why did the modelers manage to convince the entire world to jump into lockdown the moment a new pathogen appeared? My whole country literally stopped based on the evidence presented by modelers alone. And we can debate endlessly about the parameters used and the sensitivity analyses and all the very many areas of uncertainty. But one thing is certain. We know far less about COVID-19 than we know about TB. So why is the model for COVID so much more compelling than for TB? Don't get me wrong. I have the greatest respect for infectious disease modelers. I wanted to become one myself, but it turns out I wasn't smart enough. And I didn't have the looks to pull off the other type of modeling job. But jokes aside, let's talk about the biggest joke of all. And that is that TB services were almost universally dropped and neglected even further once COVID came around. Why were these compelling COVID-19 models so compelling? The other question, why did these COVID-19 models ignore other pandemics? Maybe a pandemic that presented in the same way with a cough and a fever. Maybe a pandemic that transmitted in the same way. The WHO and CDC have been reluctant to admit it, but both are airborne. Maybe a pandemic that will kill just as many people in 2020 as COVID-19, if not more. They have both killed more than 1 million people in this year alone. Yet, in my country, where TB kills more people than anyone else, we did 50% fewer tests when COVID arrived. Only 1 out of 250 people that got a COVID test in our government sector also got a TB test on the same day. We're going to take the stairs or the lift? I think the stairs are safer, right?
Yes.
I've lost count of the amount of x-rays I've had and the amount of sputum samples I've sent, because the problem is every time I cough, that could be the first cough of my TB reactivation. That's right, yes. I've got long lines there. It's a challenge to get it all up. Look at that, eh? Sakari spotted something on the x-ray, and she also then looked at the previous report and it was different.
This could be secondary TB.
If there is something brewing, then you never know when it pops up. And I've got 2 small children under 5.
This time, Arn was lucky. Although his x-ray was unusual, follow-up tests confirmed it was a false alarm.
TB is terrorizing me because it's the fear that is currently the bigger problem rather than the disease. Instead of recognizing a key opportunity to tackle both pandemics, we went with the reductionist argument again. We can only do one above the other. The pathogens love this. They work together. They are competing for the same humans, yes, but they sow synergistic suffering and death. So my question again, esteemed modelers, esteemed TB experts, why are we not taking TB prevention seriously? We haven't even spoken about the elephant in the room, antimicrobial resistance. The reality is we can prevent TB. We can prevent drug resistance. We have treatment. We know how to do infection control. We know all these things. My cry, my call, my plea to the TB modeling community is to be more assertive, be more clear. Yes, there's complexity, but there's only one message. To end TB, we must prevent TB. Thank you.
Thank you very much to all our panelists for that wonderful sessions, and what a note to end the talks on. Thank you, Arne, for those powerful, difficult questions you asked. And there was a recent article which said, the real monster is spreading, and it is not COVID-19. It's actually TB. So something for us to think about. Thank you to all our panelists. We'll be very happy to take questions now. We have been very kindly given extra time by Union because we had some problems in the earliest starting of the session. So we have some time for questions. I want to turn first to our panelists, Chatika Veerasurya, because there are some significant 3 or 4 questions for you. If you could just start off answering them, we could take it from there. Thank you, Chatika.
Thank you, Blessy, and thank you again to all the other panelists. Extremely interesting presentations. So to start with, there's a question from Finn McQuaid about the feasibility, fundamentally, of mass vaccination in countries like China and India. And quite frankly, that is the million-dollar, or should I say, billion-dollar question. Like it's one thing, essentially, for modeling evidence to demonstrate that vaccines will likely be cost-effective, but cost-effectiveness is defined almost always in terms of the single intervention at a unit level. So it's cost-effective to vaccinate one person. However, when you multiply this cost over 700 million adults, this then becomes a question of feasibility, and those two things are subtly different. This is very much underexplored. All the literature at the moment focuses on cost effectiveness, that is the utility of TB vaccination relative to other interventions. But practically what we need to address is, can this actually be done? Can a national health budget actually incorporate an enormous vaccination program, particularly for the case of China and India? This is some work that we're actually currently doing, and hopefully, with any luck, might have some results for the next union. But the short answer is, I think that it very much depends on your assumptions about how much you value a DALI and exactly who you're trying to vaccinate. If you had all the money in the world, you could vaccinate everybody magically. Yeah, sure, anything is possible. But if you're being pragmatic and you need to make decisions about who you're going to vaccinate, that, I think, will be the final arbiter of whether this is feasible or not. So that was one question. Then I believe there was a question from Courtney about vaccine cost effectiveness. Essentially, how would vaccine cost effectiveness change if you incorporate the post-TB morbidity into these questions? And I believe this follows on from a talk yesterday by Nick Menzies from Harvard, who works in this area and has essentially made the point that the amount of DALYs attributable to TB goes up quite substantially if you incorporate the post-TB morbidity. And as people here know, I mean, TB doesn't end on your at the end of your 4 months of you're at the end of your 4 for 2, 2 for 4, right? In the old regimen, you oftentimes a non-trivial proportion of people are then subsequently left with lifelong sequelae. That could be lung damage. That could be consequences of the adverse side effects of the drugs, as Arnie has demonstrated, and not just for MDR-TB, even drug-sensitive TB regimens. Those drugs are not side effect free. So the short answer here is that yes, it will just make it more cost effective, right? So essentially, when you avert a case of TB, mathematically, you'd just be averting a case of post-TB morbidity. So all of our cost effectiveness estimates should be, you would expect that the cost effectiveness would go up. The practical difficulty, however, is that, as we all know, tuberculosis is extremely heterogeneous, but post-TB is probably, I'm guessing, based on my clinical experience, as heterogeneous, if not more heterogeneous. And certainly the magnitude and distribution of post-TB sequelae have not been adequately characterized and are quite likely to depend a lot on other factors, which are not strictly kind of natural history related. So, I mean, the amount of post-TB morbidity you have is very likely to be affected by the health system that you're in, your baseline level of health, and all sorts of other factors. So if we can get a good handle, or at least some estimate of those aspects of the post-TB, if you like, environment, we can quantify it. But yeah, I think it's very safe to say that yes, once we start actually discussing and actually incorporating post-TB morbidity into our considerations, that will make any preventative therapy, not just vaccines, more cost effective. And yes, so, and then I just want to see, I believe there were some questions about treatments, some model specific questions, which I have answered in the chat, but in brief, the model that we use here is actually treatment history stratified in response to a question about the Indian tuberculosis MDR-TB epidemiology in India. We do stratify by treatment history, and in fact, we calibrate to the amount of previously treated MDR-TB as reported in the National Drug Resistance Survey. 1, 2, I believe there was a question also about what the feasibility of vaccines ever materializing is, and that is a very reasonable question. We have tried as best as we could in this model to align the characteristics of the vaccine with what we know are the results of the phase 2b trial from M72ASO1E, which was reported in 2018-19, which is sort of regarded as being the most promising avenue that we have at the moment. But ultimately, yes, it is very much a hypothetical, and I believe the kind of wider point we're trying to illustrate here is that there is value to pursuing TB vaccinations, in particular, value that is otherwise, and that valuation needs to also incorporate the costs of MDR-TB, both the clinical costs, the financial costs, and also, if you like, the social costs. Yeah, I think those were the questions for me, unless I missed any.
Yeah, thank you so much, Chatika. There's one question about the TB preventive therapy, and perhaps Courtney could answer that. Considering high risk of reinfection, what would be the duration of TB preventive therapy? Courtney?
Yeah. Thank you for that question. This model was intentionally a very short-term model about individual risk and benefit. So it's really asking this patient you have in front of you, this contact, if you treat them without testing them first versus if you only treat them if they have a test, how likely are they to develop TB in the short term versus to have an adverse event, which obviously is short term because it's related to the treatment. So the kind of time window on this is no more than a few years. The progression estimates we used only go out to 3 years. That was the limit of the data. The effectiveness estimates for TB for preventive treatment was based on the trials. So those estimates are based on the monitoring time of the trials, which is usually 1 or 2 years. So this is not considering, this is not saying it's a lifetime risk or anything. It's just the risk for that person, in the immediate future.
Thank you, Courtney. There's a question from Arne about how many of the models considered onward transmission. So perhaps all of you could have short answers to that. Who would like to go first? Yeah, okay, Chatika.
Yes, so one of the value adds of this specific work, the MDR-TB work that we've done, is that in contrast to previous models, we actually specifically dynamically represent the MDR-TB transmission process. So MDR-TB is an ongoing concurrent transmittedly disease as distinct from drug-sensitive TB. And so we're trying to capture the impact of vaccination on affecting the transmission process as well.
Yongji, would you like to come in?
Yes.
Thank you.
In our model, we didn't consider transmission because our target population was children under 5 and 15, and we assumed that their TB disease are not much transmittable and wouldn't much influence to our research question, which comparing targeted, the 3-HCP and then TB treatment intervention compared to the status quo. So we use the decision tree model, deterministic.
Pereira, anything on that? You need to unmute yourself. Yeah, thank you.
Thank you. Our model, we did use transmission disease, didn't use that for our analysis.
Okay, thank you. Courtney, anything to add to that?
Yeah, like I just said, our study was meant to be a short-term, patient benefit model, but I do want to just make a comment about that, a larger comment about modeling. Any modeling by including onward transmission as a potential consequence, all preventive measures are going to look better. And also by including post-TB, morbidity and sequelae, all preventive models will look better. If you include things like economic cost to society from lost productivity or or reduced quality of life, all of these things, if you include them, they always make prevention look better. And I think that, for these kind of long-term societal impact projection models, it is really important to consider those things because they're really the true burden of TB disease. And I think a lot of models don't include them because we don't have the data. You have to make a lot of assumptions. And, I do think there's a tension here between wanting to have a more bulletproof model that nobody's going to argue with your assumptions, but having a model that really kind of captures the reality of what TB does to people and to communities. And I think it's important to try to navigate that.
Thank you, Courtney and the other panelists. We have another question on how, I think that's for Arne. So, it's about, we have the evidence to show that every dollar spent on TB is one of the wisest investments we can make. So much of the modeling already shows we need to spend more on TB, and it's money well spent. So how do we bring this to the attention of the world better? Do we need to link modelers with advocates or try to link with departments of finance rather than health? Arne, would you like to answer that, please?
Yes, thank you. And I agree. You need to link activists with all those people. But I'm also worried that in the TB discipline, we are our own worst enemy. Not picking on anyone, but the comment about feasibility of giving everyone in China or India a vaccine, that struck me as typical of the way that we think in TB. We don't have that kind of argument when we eradicated smallpox or we ended polio in Africa now, or for pretty much every vaccine preventable disease. So if we could actually dent the biggest infectious killer in the world currently and in history, how can we even have a discussion about whether it's feasible or not? We just have to find a way. The same with COVID. We've seen that every year we get told there isn't enough money for TB. A novel pathogen comes around, and suddenly the amount of money available for investment is exponentially more for a disease that is less lethal and less transmissible. So also, as I pointed out in the plenary, as reflecting as a privileged white doctor, I think the narrative really has to change, that people that are infected by a certain disease are worth less, they matter less. If we truly believed and acted as if every life had the same value, these models would look different. And the same with these cost effectiveness analyses. What is the term they use? The willingness to pay. It's completely different in India compared to the United States. Why is that? It's the same human life. So my plea and my call, and also the plea to all the assembled experts and those listening in, is that look and think seriously about how you frame TB and how you talk about people and lives lost and post-TB disability and prevention of transmission and impact on life. Those kind of comments strike me as coming from people that have never actually been sick with TB, have never watched their loved one suffer, never had to see a loved one in ICU because of normal TB treatment. We really need to change the narrative. TB is a terrible disease and our options are terrible, and we need massive investment. And the experts can be activists. You don't need to fly in people from Africa to come and make the Africa and India to make these arguments. You can make them yourself, and we'll help. Thank you.
I wonder if I could just make a comment there, bless you. First of all, Arnie, I think the point you raise is very valid. So it's easy, right, to talk about things in abstract like feasibility and things like willingness to pay. But I guess one thing to bear in mind is when we present results, for example, for things a bit like TB vaccination, it's kind of it's a no-brainer for us from inside the field. Like, we know that it's a good investment and that every dollar spent on TB pays back on itself, exponentially, if you like. And your wider point about the fact that it is the same life, no matter where you are, is well taken. However, I guess what I'm approaching is that when we think of this in terms of the constraints that we know exist, right? Within certainly the financial constraints that we know exists, we sort of have to present the results in a way that people who use these results don't immediately dismiss us. So, like, we know, for example, that in India, the expenditure on health in India is approximately 1.5% of its GDP, which is substantially lower than what we would hope for and what is generally regarded to be required for the provision of universal healthcare coverage. And given the fact that we spent that India already spends so little, comparatively speaking, certainly from the public health sector perspective, on healthcare provision, we have to frame things like the provision of a universal mass campaign of TB vaccination. We have to kind of keep that in perspective. Like, if you then go to someone who's working under some, such constraints, like a Ministry of Finance, and tell them, actually, we know that if you were to spend another $2 to $3 billion on this adult mass campaign for tuberculosis, it will pay itself off, they would respond, where do we get $2 to $3 billion? And again, I think there's this tension between what we know must be done and what is objectively is a strong word, but what is evidentially the best thing to do, and I guess the sort of practical limits that we're hitting. And I feel like that isn't necessarily, it's not a reflection on the fact that we devalue TB or people with TB. I guess perhaps it's being overtly pragmatic, if you like, but it's an attempt to cope with the reality, certainly of the financial situation. And that's why I think we make this distinction between feasibility and cost effectiveness. As Courtney pointed out, once we incorporate the actual downstream effects of preventing a case of TB, like just the leaving aside the human costs, right? Once we actually just purely the financial savings, it's enormous. Like it's such a no-brainer. But the problem is the scale of the and directly from that, the ability to proceed to it. And even COVID interventions, as you point out, it's very COVID is this odd case, and it shouldn't really be, but even those are already receiving pushback. But yeah, I take your point. But to summarize, I take your point that we need to perhaps feasibility belies the need for it, but we do also have to bear in mind the constraints of the systems that we're working in when we present or when we say the things that we do, because what's less useful than our work not saying what it needs to say is just being disregarded, which is a risk, I think, if we present results which are essentially...
Draw you to a close there, Chiquita.
Yeah.
If I could, sorry. So, look, I think it's been a very interesting discussion. I think Anne's point is a very strong one, though, that essentially we have set our sights too low. We keep sort of trying to say these are poor countries, therefore we can only do poor things. And that is not actually an adequate frame with which to view this problem. There is a problem, we need to see the scale of the problem, and we need to deal with the problem adequately. I believe we see. The other thing I think that we do incorrectly is to look at the cost per patient detected. Or the yield, that is a useful metric if you're the donor paying for it, and it's often the way in which these things are constructed for the purposes of justifying the expenditure of donor funds. But actually, what we want to do, the objective is to end TB, and the outcome should be the extent to which the intervention progresses us towards ending TB, not the cost per patient detected. I feel that estimate using yield as an outcome from studies of the cost per patient detected is the wrong metric and sends the wrong message about what we're trying to achieve. Having said that, I just want to ask a couple of questions, if I could, because somehow or other this chat function does not allow the chairs to actually put questions into the thing. So I'm going to use my chair's prerogative to ask a question. And I have a question for Dr. Zindonga. Your talk was very interesting and comes back to this sort of optimizing the allocation of resources. So despite what I said before, I think it is important to optimize the allocation of resources. But I would say we should not assume that the resources are just those that we have now, because we can see from your presentation that optimizing the allocation of the resources that you have now produces only a very modest benefit in outcomes. And so we have targets for ending TB by 2030 or 2035. So what I would want to ask you is it possible to use the optimum model to work out what resources would be required, if optimally allocated, to actually reach the TB elimination goals by 2030 and 2035 for Mozambique? Just remind you to unmute.
Thank you for the question. It's a good question. In our study, we didn't estimate budget for achieve NTB target, but in our model, we show that the increase the budget could reduce the number of active TB infection, TB-related death, and reduce the rate of TB incidence. But also we found out that even if we double the current budget, it's not be possible to achieve NTB target in Mozambique. The problem is the TB program is unfunded in Mozambique. And even if we double the current budget, we will not achieve the target. And we still reanalysis to found out if optimized budget, how much we will need to achieve the target. Thank you.
Okay, I think we've more or less, there are a few more questions in the chat. I think maybe the panel might want to respond to those by typing responses if they wish to, because I think we're just about coming to an end of the session. Maybe I might just take the opportunity. I've already made one proclamation. I might just summarize by ending. I think this has been a very fascinating presentation, the set of presentations, and does show the power of modeling to make projections and to help strengthen policy and the allocation of resources. I would just reiterate the statement and perhaps restate the plea that Arne made, that we, instead of just looking at how we can best allocate the resources that we have now, what we need to do is work out how we can most effectively use the tools that are available to us now, and perhaps new tools that will be coming online, to achieve the TB elimination targets within 15 years. And what resources will be required and how to optimally assign those resources in future. I think that modelling does have an important role to play in that. And I'm grateful to the contributions that all of you have made, not only today, but in all of the work that you're doing to assist in that task. So thank you very much. And on behalf of myself and I think Blessy, I can say thank you very much for your contribution, and thank you to Blessy for co-chairing this session with me. So thank you very much.
Thank you.